Good afternoon and welcome to United TV. It's our Bariatric Friday session with Dr. Irgau. Dr. Irgau, how are you doing today?
I'm doing great, Kemal. I'm very happy to be in this wonderful studio for yet another great session.
No, it actually it's changed our habits, so it's good to have you here. And it's much it's different in a good way. So let's just say that
Wonderful.
I'm glad that we are able to do it, and I'm glad that it works out with your schedule and our schedules. So bariatric surgery is what we do. Our main job, main work for this program is focusing on morbid obesity and providing different tools for those who are struggling with morbid obesity. And our goal is to bring different topics each week, every other week, and making sure that the individual is prepared for what's coming for them. And that's kind of like what we are trying to do for this session. And each week, as we are providing new topic, idea of getting you ready for the surgery is 80% of the work that we are doing. Today, we are going to actually look into day of the surgery. Now, we had some discussions in the last couple of weeks, Dr. Irgau, and for certain things that should be so like kind of standard, straightforward, I just realized that it's not. So some of the discussion that we had with our providers, well, one of my friends who's now having a surgery, hey, like when you really need it, it's not really that maybe straightforward. So as much as we do all these things and getting everyone ready, this, that, but there's always this key point of, hey, what was I going to do before, or what was I going to do there, and then right after. So if we can actually just walk the patients through for the day of the surgery, and what do they expect before the surgery, and the day of the surgery, and the right after.
Absolutely, absolutely. So we can actually look a little bit into the immediate before surgery time frame, right? Patients will be on a special diet that we call Robert diet, but it's actually the new direction diet from the Robert Corporation. And it's a meal replacement diet that we want patients to be on for about 2 weeks, sometimes 3 before surgery, for them to be able to reduce what's called visceral fat. And that is the fat in the abdomen, primarily in the solid organ like the liver. Because when we are heavy, the liver tends to be very large and very dense, and the liver covers the stomach, which is the main target of our procedure for surgery. And for us to be able to move the liver very easily without too much challenge during the surgery, we place patients on this diet, which will shrink and make the liver a lot softer and makes the surgery much less challenging. So patients will be on that diet, and they will be towards the end of that diet at the time that they are ready for the surgery. They will be obviously receiving instructions from our office as well as from the surgery center about what to do the night before surgery, the day before surgery, for instance. And one of the important points will be what to do with their medications. And there are certain medications we want them to continue taking, and there will be some other medications that we want them to hold off. And these discussions obviously are individual. There are certain medications actually that we want the patients to take even before they come to the surgery. One of those medications is, for instance, is Tylenol. Although patients are instructed not to have anything to eat or drink after midnight before the day of surgery, we want them to typically use a sip of water to take medications that are necessary. And one of those medications will be extra strength Tylenol. Now, people are used to think of pain medications to be taken after surgery, not before surgery. But we do have this special protocol in our surgery center where we are actually preparing the patient to have less discomfort by priming their body, their system really to be much less uncomfortable after surgery. And one of the ways to do that is to prepare them by having them take pain medication like Tylenol before the surgery. And we ask them to do that before actually they leave home to come to the surgeries. At the surgery center, obviously, they will be received by our nurses while they will be doing the preparation for the actual surgery. Now, the surgery itself even for the more complex surgeries like gastric bypass, takes typically about an hour and 15 minutes, an hour and a half. This is the actual surgery. But there will be a preparation period before then, where the patients will be prepared by the nurses and they will be meeting the anesthesia staff, and then, of course, the surgeons as well. That preparation typically entails them taking some additional medication, like antibiotics, for instance. Antibiotics are an important component of the medication we give patients before surgery because that minimizes the risk of infections, right? And another medication that they will be given is a blood thinning medication, or Lovenox. And that medication is very, very important because it's one of the methods we utilize to minimize the risk of blood clots during surgery. So all these preparations, as I'm talking, obviously, are geared towards really preventing problems, right? Staying ahead of the issues. And typically, when we talk about the risks of the surgery, we tell our patients that, you cannot bring risks of surgery to zero, but you can minimize them to a great deal by taking preventative measures. And in our program, we focus on prevention, and we've been really successful in minimizing complications by taking these preventative measures, whether it's giving antibiotics before surgery or the blood thinning medication that I'm talking about. So all that preparation may take about an hour and a half, maybe 2 hours. So patients typically will be asked to come to our surgery center at least a couple of hours before their intended or scheduled time for surgery. And of course, it is at that time that they will be meeting the anesthesia staff as well. And the anesthesia staff obviously are the providers that are going to be critical in getting the patient to go to sleep during surgery, because obviously people go under general anesthesia for bariatric surgery, and general anesthesia requires an anesthesia provider to be there, obviously, to help us get the patient safely under anesthesia before the start of the procedure.
So I think what I'm maybe kind of thinking now, of course, there are exceptions, but then sometimes those exceptions are a little bit more than what we are expecting. Now, here I'll tell you what my exception would be. If I have 1 out of 150 patients making a mistake on the instructions, that would be an exception. But if it's 5 out of 150, that's still a decent number of people who have this understanding. So what would be the best way for patients, or what do you think patients are missing for the prep standpoint? Like, hey, was I going to do it, or was I not going to do it, or should I have reported this? Should I have reported this, or should I not have reported this? Like, what are they missing for those who are not maybe understanding everything that we are giving them?
So these are important points. Obviously, our instructions not only have to be clear, but they have to be repeated on different occasions. It has been shown, for instance, very often that when patients are given instructions, they may not retain that information on the first go, just because there is the anxiety, there is the mindset that may not be set up to just get that information. So having the information repeated by different components, members of the team, is very important. So for instance, we talk about this, when we see our patients in the office, but then patients talk to the staff in our office, but then they talk to the staff in the surgery center, where the information is always consistent, right? So for instance, a very important thing that patients need to know is that they shouldn't have anything to eat or drink after midnight of the day of the procedure. This is an important piece of information. But then at the same time, what would they do if they have medications that they have to take? If we tell them you cannot have anything to drink or to eat, but then they have to have medication. So we have to be clear in our instructions about what they can take. And on top of that, obviously, patients may have specific medications that we want them to avoid taking. For instance, a good example would be patients who are on metformin. Metformin is an anti-diabetes medication. And typically, we would ask them to hold off on that medication if they take it in the morning, right? Because we don't want their blood sugar to go too far down during the surgery. Another medication that is important for them to understand about it, and also is common with our patients, is a blood pressure medication. Okay? Right. Well, we tell them, take your blood pressure medication because, blood pressure tends to go up at the time of stress and anxiety, and if they're preparing for surgery, understandably their blood pressure is going to go up. So if they take blood pressure medication, the last thing we want them to do is hold off on that medication. We want them to take that medication, right? So those type of instructions, if they are repeated by different members of the team at different times, obviously the chances are that the patients will retain the information and they follow the information. One of the misunderstandings that comes up sometimes is we ask patients, for instance, to take Tylenol extra strength as part of their preparation to minimize discomfort, and we ask them to take that with a sip of water in their home. But we've had the occasional patient who takes Motrin instead, and now Motrin is one of those medications that we want them to hold off before surgery because they can increase the risk of bleeding. And mistakenly, patients, not understanding the difference between Motrin and Tylenol. Some patients have taken Motrin in the past. So we try to be as clear as possible in our instructions, but as I said, also repeat these instructions from different component members of the team so that patients will retain that information and more are likely to follow it accurately.
Now, between the different surgery types, maybe let's just rephrase the question. Between preparing for bypass versus sleeve, are there any differences for the day before?
No difference at all. No difference at all. So patients will be given the same instructions in terms of how they will prepare with the diet, for instance, the 2 weeks before, and the instructions that they will have coming to the surgery center will be exactly the same as well. There's no difference. So what may be a little bit different in terms of their stay in our surgery center is that the surgery for the gastric bypass may take a little bit long, by much, maybe 15, 20 minutes more, occasionally 30 minutes more than the sleep. That is really the operative time. But the actual time that they will be spending at the surgery center in total will be the same. Patients will come a couple of hours before they have allotted time for surgery. And then we will be talking about post-surgery recovery, but patients will typically stay in our surgery center for 6 hours, sometimes 8 hours. The typical number of hours is really 6 hours. And then what they will be doing right after surgery is very much the same as well in terms of the medications that they will take, in terms of the timing of their level of activity, get up and walk after surgery. Those are the same whether they're having gastric bypass or the gastric sleeve.
So when they are in the surgery center, they come a couple hours before the surgery because they need to be prepped. No jewelry, no makeup. Right. So those are kind of pretty standard. But for the sleeves and bypass, should they expect anything more than if it was any other general surgery?
They do not. In fact, really, the preparation, the essential preparation really is for general anesthesia. And general anesthesia is pretty much standard for all those procedures, essentially. And there are some instructions, as you mentioned, for instance, one of the methods that the anesthesia team monitors the oxygen level in patients is by placing a device over the tip of their finger, right? So having nail polish, for instance, can interfere with that. And very often we will tell patients that would be important, for instance, therefore them to have. But these are instructions that the team that calls the patients beforehand will be going through with the patients. Prior to the procedure, typically it's a couple of days before the procedure.
So they had their pre-op preparation, they had their surgery. Usually surgery takes about 85 to 110 minutes, depending from in and out.
Yes.
Total, and then they go to the PACU, and that's where that discharge time actually starts, 6 to 8 hours. So the extremely important part is first hour. So we do something different for our patients where the pain and the nausea and all those are a little bit less.
Absolutely.
Can we elaborate that?
Yeah, absolutely. So as you mentioned, the surgeries in our program are done by and large in an outpatient setting. and particularly the patients who come to the American Surgery Center, are expected to go home the same day. Of course, our patients know that if we need to keep somebody overnight, we have the capability of doing that in our surgery center. But when you have the data yourself, Kemal, being the head of the surgery center, you haven't had really to keep any patient in the surgery center overnight now for a number of years, I would say, right?
Well, I don't remember the last
one. You don't remember the last time. So yeah, typically patients will go home. So what do we have to do to get patients to go home the same day, right? First of all, we have to be able to make sure that patients are stable, right? So we monitor them very carefully to make sure that there is no sign or evidence of any serious complication. And that's why we have those 6 hours in which patients are monitored very carefully, right? But then what we also want is we want patients to go home and be comfortable with a low level of pain medication. And we don't want them to be taking really strong pain medications that will be messing with their head, with their ability to move and do things in an unmonitored setting, right? So, but for us to be able to do that, we have to really implement methods of minimizing discomfort for surgery. And that's the methods we have, right? And it starts even before the surgery. Before the surgery, as I mentioned before, we give medications that will preemptively minimize discomfort after surgery. And we also utilize medications that will decrease nausea. Nausea that is so common after anesthesia is actually extremely uncommon among our patients because of these medications that we are able to utilize. But then the other things that we do come out is that during the surgery, we strategically place numbing medicine around the abdomen in areas where we are able to numb the nerves that supply the abdomen. So our patients actually, they wake up from surgery comfortably, right? And the example I give myself is that throughout my training and throughout most of the time of my career, throughout the last 25, 30 years, Kemal, I remember patients waking up from anesthesia in discomfort. They will have a big frown there because of the incisions that hurt. But anesthesia do not want to give them too much pain medication because they want to wake them up. They don't want them to stay asleep, right? But now I don't see that because the methods we utilize are so effective that patients have very little discomfort in their incisions as they are waking up from anesthesia. And this is extremely important, not only because we are compassionate and we don't want our patients to be in pain, but also because it really leads to excellent recovery, right? Patients are able to be up and about early. And getting patients to be up and about early has many advantages from a recovery from a surgery point of view. One of the most important advantages is that we are able to minimize complications like pneumonia, like blood clots, because we're able to get the patient to be up and about early. But I also do believe that getting patients to be in a vertical position soon after surgery creates a mindset that enhances recovery, as opposed to staying in bed, looking at everybody really above you, right? And taking on this role of the sick person, right? That mindset actually makes you even...
It does work, actually.
Right, makes you even sicker, right? But if you're up and about and you're able to look at people on the level, right? Because they are upright, you're upright, then that mindset actually works well in creating really a mindset of recovery. And patients do recover better when we are able to do that. So by the time patients are ready to be discharged, the discomfort level is very low. Virtually no nausea or vomiting at that time. Patients are able to drink something. They're able to walk independently. All those things have to be fulfilled, obviously, before patients can discharge. And obviously, this it goes without saying that they have to be stable from their vital signs point of view as well. And
now, that mental issue, mindset is really so important. When I don't feel so great, I try to get out of the house because I know that if I'm in the office, I'm going to focus on that a little bit less. Or if I'm able to take a walk, then it's going to be less. But if I'm just almost like celebrating for being sick, I get sicker. So
absolutely,
it's the same mindset. Like if you act like you are sick, then you are going to be sicker. Or it's going to take a little bit of time to heal. But I learned that from you. But I didn't know what I was doing with myself, with uh, uh, being home rather than being in the hospital is better for the patient. That was a huge change for me.
Absolutely.
In fact, initially, I probably said it a couple of times, but can it be true? And yes, it is true. And the same mindset, like when I'm, like, let's say if I'm cold, if I'm able to walk a couple blocks, I feel better. But if I'm just trying to just stay in bed and then not get out of the bed, usually that takes longer to heal from that. So that's the mindset.
Absolutely.
So,
It's interesting, actually. I saw a patient in the office yesterday for a general surgical procedure, not for bariatric surgery. And the gentleman was telling me that his dad had hernia surgery in the 1960s and was in the hospital for almost 2 weeks.
a long time.
Okay. And then this gentleman himself had hernia surgery in the early 80s, and he was in the hospital for about 5 days, counting the days before as well, right? So he would come to the hospital like a day before, sometimes even two, and then they would be in hospital for a while. And when you do that, you're actually creating the role of the sick person, right? Because the patient says, okay, now for all these days, I'm going to be sick. I'm going to be in a horizontal position. I'm going to lie down. People are going to come to the hospital to visit me, or he's sick, so they visit you. So recovery doesn't come to your mind at all. But all that actually creates so many more complications in terms of your ability to heal, your ability to nourish yourself, your ability to be up and about and breathe comfortably, so avoid pneumonia and avoid blood clots, right? I mean, when doctors realize that one of the best ways to get rid of blood clot as a risk, or minimize blood clot as a risk of surgery, is actually to get patients moving. That was just a huge revelation, because before then, patients were told to stay in bed after they had surgery, right? And yet that increases the risks, right? And now we've come so far where we're doing complex operations like gastric bypass, like this sleeve hysterectomy, with small incisions, and patients are able to go. So we're doing this safely. We're doing this with all the appropriate preparations and protocols in place, and getting great results. But not only that increases the satisfaction of patients, right? But also it enhances their recovery and minimizes complications, right? Not to mention about the other advantages that obviously are important, which is we're decreasing the cost of healthcare, because we're not keeping patients in hospital, in bed, a long time. Then also all the other advantages of avoiding a hospital where there are a lot of other sick people around, right? So if you're coming for an elective procedure that can be done in an outpatient setting, why would you want to go to a place in a hospital where understandably there are a lot of other sicker patients as well, right? So everything that can be done at the surgery center is best done in the surgery center when it can be proven that it can be done safely. Clearly, not all our patients can be operated at the surgery center. If patients have severe heart disease, kidney disease, or other problems that require longer hospital stay, we will obviously operate
really high BMI.
Absolutely, very, very, very high BMI.
Although I have to tell you this, one of our patients that we kind of use that patient as the pilot for our new program lost 80 pounds before surgery.
Amazing, right?
80 pounds in 2 months.
Wow, a great preparation.
Like 78 pounds.
That is
78 pounds.
Yeah.
So now he's getting ready for the surgery. I think it's next week, maybe. I'll tell you after the session. So I was like really happy for him. Like, because when we started, I didn't think that was going to be possible.
Yeah.
But then when you see the process, and then if they are following, I think one of the issues with it, and that was something to do with my question earlier. If you understand, if you put the effort as the person, if we put the effort and say, hey, okay, this is what it is, this is what they want us to do, then we do better. If it's the same thing with the program, if they understand exactly why they need to do certain things in certain ways, the outcome is always better. So, and personally, like when we actually have these issues, we see it.
Yeah.
So, we are either fully in it or we are not. But if
Right.
we're half in it, we expect the full results. Guess what? That's not happening. So
True.
now we are home after the surgery. Now I'm going to ask the question in a different way. For someone who had gallbladder surgery or appendix versus someone who had bypass, I know from the eating standpoint there will be differences, different expectations. But in terms of taking care of the patient, are those three pretty similar?
So they are similar, but the patient population could be different, right? For instance, patients who are undergoing bariatric surgery are more likely to have comorbidities or complications of obesity that would require attention. One of those that are important for us is sleep apnea, for instance, right? So if patients have sleep apnea, we want them to continue to use their CPAP machine when they go home as well. We want them to stick to the medication that we give them for discomfort. For instance, if when they go home, the vast majority of patients will be taking non-narcotic pain medication. And this is very important, particularly for patients with sleep apnea, because we don't want them to be suppressed in their alertness, right? Because one of the dangers with sleep apnea is that patients may stop breathing during their sleep, and if their oxygen level goes down because they're not breathing and their CO2 carbon dioxide builds up in their system, there has to be some type of alarm in their brain that wakes them up and jolts them into taking a deep breath and waking up.
So for those who are listening, obviously, so when someone is snoring and you hear them snoring for like 20 seconds, 30 seconds, and all of a sudden there's that big high snoring, and then they wake up, that's the point
That's exactly
of the body actually is waking them up. Hey, you are about to.
Well, it's dangerous, right?
So sleep apnea is the condition that that has different stages, different levels. Not every sleep apnea is the same. So from mild to moderate to severe. So if someone has a moderate sleep apnea, if they don't have an APAP machine, when they go home with the heavy medication, their body may not respond as quickly as they would normally. Yes, because now there's too much stuff going on. That's why it's important for those patients to be more careful.
Absolutely, absolutely. So one of the important things is that patients who are on a CPAP machine must continue with that in their post-surgery recovery time as well, right? Because we don't want anything like lingering anesthesia effects or anything like that to suppress their alertness, essentially, or to make their sleep too deep, essentially, right? So if they're using a CPAP machine, we want them to continue that. And also we want them to follow our instructions. So if a patient, for instance, is going home and the medications that we use are non-narcotic medications, right? So we don't want them to use any non-prescribed medications. We don't want them to say, okay, my loved one has some narcotic and I'm going to take it. Absolutely no. Those are very important. If they do need stronger pain medication, they need to talk to us.
No one is trying to kill them.
And we need to take care of them. But it's important for patients to follow instructions. Now, you did mention the difference about diet. Of course, there are important differences in diet advancement and diet progression after bariatric surgery compared to other surgeries. But one of the important things, for instance, Kemal, is that patients need to be hydrated, right? But at the same time, because of the changes in the size of the stomach after bariatric surgery, they're not going to be able to grab a big bottle of water and just finish it because they're thirsty. They cannot do that. So we teach them about strategies to get hydrated, right? And one of the best strategies is for them to sip small amounts of water continuously whilst they are awake. So we tell them,
I still do that here.
There you are, absolutely. So we want them to do that, right? We want them to stay hydrated. And then the typical question they have is, but how much water can I drink in one session? Well, the answer to that is very individual. We want them to start learning and understanding the feedback that their stomach gives them about when they are full, right? And that could be different from person to person. Somebody could be full after 2 ounces. Another person may require 6 ounces. So we want them to navigate that and to have a essentially to learn as they go what their stomach will be aligned. And so to do that, obviously, they have to be mindful, as they are drinking. So hydration is important, right? And sticking to the guidelines we give them about staying on a liquid diet, for instance, for the first 2 weeks is very important. The reason this is very important, Kemal, is that their stomach is healing. If they eat, let's say, a burger or something like that, for beef, and big chunks enter their stomach may not be able to handle that as it's healing, and that could lead to disruption of the wound in the stomach, which is a very, very dangerous complication, essentially. So when we tell patients, please stick to the liquids, it is very, very important for them to understand that.
And they get enough calories from that. So if they get enough calories,
absolutely. Hunger is not an issue. Hunger is not an issue. It's really that if people don't understand the gravity of the consequences of not following these instructions, they may just try it, and then that could have dire consequences, obviously.
No, I mean, it's, I always come down to, because knowing what we hear from different people, different patients, they don't pay attention. They don't pay attention until things starts happening. And I'm not talking about majority, I'm talking about those who are struggling, they didn't pay attention. So if I don't pay attention to right now and not knowing what's coming next, my prep is going to be different.
Right.
So if I just say, hey, this is a clinical show, well, let Dr. Erkan talk, and then not pay attention to what you are saying, I will not pick up certain things that you are saying. Same thing. So some patients, they do not listen. So all I'm asking them to do is, there's so many different reminders that we have, so many different sources, resources that we have. Well, this is one of them, obviously, but there are the hidden, the written stuff in our website, in our offices that's given. So make sure you read that a couple times until you have all the questions answered, because once you complete those couple weeks after the surgery, things are going to go back to your new norm, not like the old norm. Like you should be eating like with the bypass, especially like the huge hamburger. You won't be able to eat it anyway. So, but if you had sleep and then you feel better now, you shouldn't really. You won't. Number one, you won't feel like you need to eat that.
Right.
So that big part of that stomach that's telling you that you're hungry is gone.
It's gone. Yeah.
So this is I try to emphasize this since we discussed this in the beginning. Many people don't understand. We're not just cutting and taking the stomach. That's also the part that tells your brain that, hey, I'm hungry, go send me more food. That part is gone, so that the hunger feeling of that is not going to be there. So there is no reason to be an overachiever after the surgery. But you can be an overachiever for good things. You can, do your physical exercise, physical activities, hydration, taking your vitamins on time. Those are the ones that we want you to be overachiever.
Yes.
All right, Dr. Ergau, I think we covered this topic, and I think we have another one coming up next week.
Yep.
After that will be 2 weeks. We want to have the live one, but we'll have our premiums say.
Yeah, absolutely.
So this week is going to be an important week for people in Delaware. Primaries are on Tuesday. If you are registered Democrat or Republican, this is time for you to go out and vote. Now, if you are not registered, and if there's no primary for what you are looking for, you may not be able to vote anyway. So only if you are registered, you can. Early voting started. It's important for the state of Delaware. I'm hoping that everyone is well informed. If not, go back and watch our 2 p.m. sessions. So we covered that enough. But until next week, stay safe. We'll see you soon. Thank you.
Bye-bye.